So the management of acute phase of cluster headache is 100% oxygen and nasal or subcutaneous somatoplan. And one other important thing to remember about cluster headache, if the person is having a first episode of a cluster headache, then you may need to refer him or her to a specialist uh, because it may require a CT scan to rule out other differential diagnosis of cluster headache. For the prophylaxis of cluster headache, the drug is calcium channel blocker. For the prophylaxis of migraine, the drug was propranolol first line, and the second line was topiramate. Now we have a scenario, an example to make things.
Sorry, Doctor, can this verapamil or diltiazem can be used for migraine headache as well? Because I had a
No,
patient
there.
today. She was prescribed by the consultant. Her migraine was not controlled. So the consultant asked that she should start because she used everything, topiramate, everything, but her headache was not going. So the consultant advised that she should be prescribed verapamil. So just a question, like, I don't know, because you said it's just for the
There
cluster.
are no study guidelines or research-based guidelines that verapamil is useful in the prophylaxis of migraine.
Right.
But because
Yeah.
her symptoms was not improving with the drugs which
Mm-hmm.
are recommended for migraine,
Mm-hmm.
maybe the consultant was thinking about some alternative diagnosis like cluster headache because the
Okay.
symptoms of these two overlap much.
Mm.
That's
Okay.
why he may have switched the medication.
Mm-hmm. Okay. Thank you.
So a 30-year-old man presents complaining of severe headache in the last 2 hours ago. It is localized to the left side and associated with photophobia. So as you can see in this scenario, the man is complaining of headache that lasts for 2 hours. It is localized to the left side and associated with photophobia. Left-sided headache associated with photophobia. He suffered from a similar episode a few months ago that had also involved the left side. It had lasted for several minutes for several times a day for a period of 2 weeks and then subsided spontaneously. The patient is unable to stand still, agitated, and anxious. What is the most likely diagnosis in this scenario?
Cluster headache.
Cluster headache. What are the points that are favoring the diagnosis of cluster headache?
Because it started 2 hours ago and then it is unilateral. Then there was similar episode a few months ago, and yeah, it lasted for several minutes, and then again after 2 weeks, another it was spontaneously resolved, and then there was another attack. So the agitated and anxious is again goes for cluster headache.
What will be the appearance of patient in case of migraine?
That patient would like to stay in a dark place and just to be like in a like be resting and not agitated.
Yes, that's right. And plus, in the patient with migraine, one attack will last for several hours to several days. While in this case, the person is getting several times a day, an attack several times a day. So these 2 points, and furthermore, the patient is unable to stand still, agitated, and anxious. So it is most likely cluster headache. Yes, your answer was right. Now we discuss tension headache. cluster headache and migraine. Now, a new type of headache, which is due to idiopathic intracranial hypertension, which is also known as pseudotumor cerebri. The symptoms of idiopathic intracranial hypertension is that the pain is bilateral, like tension headache. It is also bilateral. Like migraine, it can also have visual symptoms, including loss of vision, which can last a few seconds, and visual blurring as well. There can be papilledema on fundoscopic examination of the retina, and the pain is worse in the morning and better on standing, and also aggravated by coughing or straining. So these are some important points to remember to diagnose idiopathic intracranial hypertension. That the pain due to idiopathic intracranial hypertension is worse in the morning, and it gets better on standing, and get get worse by coughing or straining. So remember these important features for the diagnosis of idiopathic intracranial hypertension. The cause of idiopathic intracranial hypertension is increased CSF pressure due to unknown reason. That's why it's called idiopathic intracranial hypertension. Maybe the water content of CSF increases, due to which a patient develop increase in the intracranial pressure and these headaches, which are worse in the morning, better on standing, and aggravated by coughing or straining. The management of idiopathic intracranial hypertension is losing weight if needed. If the patient is overweight, then you will advise him losing weight and limiting salt or limiting fluids or salt in the diet. Or sometime a shunt may be placed if the patient symptoms does not improve with the lifestyle modification and the symptoms are worse. Shunt or diuretics can be used in such cases. So headaches and their causes are completed. Now our next topic is epilepsy or seizures. So headache
Sorry,
can be due to
I have a question regarding this shunt. How is this shunt put in this intracranial hypertension?
intracranial hypertension. As I told you that the patient may experience these symptoms due to increased CSF pressure. So to decrease CSF pressure, a shunt is placed between the brain and in the peritoneal cavity. A tube is usually placed that communicate or connect these two cavities, and CSF fluid is drained in the peritoneal cavity,
Okay, that's
which
fine.
is known as ventriculoperitoneal shunt or VP shunt.
Okay, thank you.
Anyone else want to ask any question? Okay, so our next topic is seizure and its types and epilepsy. So what are the types of seizures that are usually asked in the Plab 1 exam? Seizures can be partial seizure or they can be complex seizures. Partial seizures or complete seizure. What are partial seizures? Partial seizures are those partial seizures are also called as focal seizures, as they involve one muscle or a group of muscles. Partial, there are two types of two further types of partial seizures. Partial seizures can be simple and they can be complex. If a person with partial seizure has loss of consciousness, then it is called complex partial seizure. And if there is no loss of consciousness, then it is called simple partial seizure. So, partial seizure basically it involves one muscle or a group of muscle. They can be simple or they can be complex. If one muscle group is involved without loss of consciousness, then it will be called as simple partial seizure. And if there is loss of consciousness, then it will be known as complex partial seizure. Seizure can be generalized seizure in which whole body is involved. Generalized seizure can be tonic in which the body become rigid. They can be clonic in which there is jerky movement of the body, or they can be tonic clonic. The body first will become rigid and then it will have jerky movements. They can be myoclonic in which there is no rigidity and no loss of consciousness, just jerky movements for less than 1 second. And what are absence seizures? Absence seizures are seizures in which there is no movement at all, no tonicity or no jerky movements of the body. They are common in the children. The children will just blankly stare in the space without blinking, and the seizure may last for 5 to 10 seconds. A post-ictal state may also be present in case of absence seizure. Now, another type of seizures in the children are reflex anoxic seizures or blue breath holding spells. They are common in toddlers, mainly 6 months to 3 years old. The precipitating factor for reflex anoxic seizures or blue breath holding spell is that there is a minor injury or pain or due to fear. A baby will start crying, and due to crying, oxygenation of the blood will not occur, and oxygen supply to the brain will be reduced, and the child will lose his consciousness. So this will be called as blue breath holding spells. Due to crying, due to excessive crying, proper oxygenation of blood does not occur, which leads to a decreased supply of oxygen to the brain, and which results in the child losing his consciousness. It's blue breath holding spells. What is reflex anoxic seizures? Anoxia means no breathing. In blue breath holding spells, the child become blue. So that's why it's called blue breath holding spells. While in reflex anoxic seizure, due to fear, vagus nerve is stimulated, which leads to asystole, stopping of the heartbeat to contract. And as the heart stop beating, so there will be no blood supply to the brain, and the child will become unconscious. So this one is called reflex anoxic seizure. In blue breath holding spell, the child will turn blue, while in reflex anoxic seizure, which is basically reflex asystolic syncope due to vagal nerve stimulation, the child will become pale or white. So they are also called as white breath holding spells or attacks. You are usually not asked to differentiate between these two in the Plab 1 exam. So it's not important to remember the differentiation between these two. The management of both of them is same, that you need to reassure the patient, reassure the parents that these spells are not harmful and there is a spontaneous recovery in both cases. Just ask them to put their child in the recovery position during the attack to prevent aspiration of any fluid or vomiting or content of vomitus during this attack. You will ask the parents to put the patient or the child in the recovery position. Remember that reflex anoxic seizure or blue breath holding spells, how you are going to differentiate these seizures from epilepsy. The important point to remember is that the important diagnostic point for the diagnosis of epilepsy is that there's tongue bite during an epileptic attack. So if there is no tongue bite, only that the child become unconscious after crying, then it is reflex anoxic seizure or blue breath holding spell and not epilepsy. Tongue biting is an important point to differentiate it from epilepsy. So this was all about the types of seizure. Now the management of different type of seizure. The management of reflex anoxic seizure is already discussed. Advise the parents to place their child in a recovery position until the episode ends. The episode is usually 1 to 2 minutes long. And also, if they ask you about the investigation which you need to order in these cases, then you need to check the ferritin level and treat iron deficiency anemias if present. Now, our next topic is status epilepticus. What status epilepticus? Status epilepticus is a single epileptic seizure that lasts for more than 5 minutes or 2 or more seizures within 5 minute periods without the patient returning to the normal position. So either a single episode that lasts for more than 5 minutes or either 2 or more seizures within a period of 5 minutes without the patient becoming to a normal position is called status epilepticus. What is the management of status epilepticus? First line management is IV lorazepam. If the patient has an IV access or if the patient is in the hospital, then the first line treatment is IV lorazepam. And if there is no IV access or the patient is in the community, then buccal midazolam, rectal diazepam are our first line treatment for status epilepticus. Remember that two separate doses will be repeated for the first line management. So two doses of the first line management will be given, and if the patient condition does not improve, then we will go to the second step of the management of status epilepticus. And what is the second step in the management of status epilepticus? The second step is IV phenytoin. Again, two doses of IV phenytoin will be given. If there's still no improvement, then the third step is to refer the patient to ICU for intubation and IV phenobarbital. So first line is IV lorazepam if in the hospital or if the patient has an IV access, and if patient is in the community or no IV access, then rectal diazepam or buccal midazolam. If after giving two doses of the first step management there is no improvement, then we will give IV phenytoin. And if there's still no improvement in the condition, Then the third step is to refer the patient to ICU for intubation and IV phenobarbital.
So in the second step, you give 2 doses of IV phenytoin, and in the third step, when you refer to the ICU for intubation, then again IV phenytoin is given, or it's like then that it makes like about three.
IV phenytoin is different and IV phenobarbital is different.
Okay, okay, okay. Yeah.
Phenobarbital can cause respiratory depression. So that's
Uh-huh.
why you need to intubate the patient first to start an IV infusion of phenobarbital.
Okay, okay, got it.
It means completely sedating the patient or general anesthesia.
Yeah, yeah.
Absence seizures are already discussed. They are usually present in children who are less than 10 years old and in which there is loss of awareness or the patient stare blankly into the space and will not respond to their surroundings. And during an absence seizure, the child face may look pale. It may be accompanied by upward turning of eyes or eyelids may flutter. Seizures start and finish abruptly, and occasionally his head, arm, or legs may shake once or twice. The diagnosis of all types of epilepsy is made on the EEG. We also need to check full blood count, glucose levels, ECG, MRI, and other to see if there is any other underlying cause of the seizure. The outpatient management for every type of seizure is the drug of choice for all the seizure is sodium valproate. So now how to differentiate non-epileptic attack disorder from epilepsy? Again, the important point to differentiate epilepsy from other type of seizures such as reflex anoxic seizure and non-epileptic attack disorder is if there is no tongue bite during a seizure, then it is not epilepsy. So the features that are important to remember to differentiate between epilepsy and non-attack epilepsy disorder, non-epileptic attack disorder are that during epilepsy there is drooling of saliva, there is tongue biting, there is urine and fecal incontinence, and there is a post-ictal confusion. So during the attack, there will be tongue bite, urine, and fecal incontinence in true epilepsy. While in psychogenic epilepsy or non-epileptic attack disorder, there will be no tongue bite, no urine or fecal incontinence, and there will be no post-ictal confusion. In case of epilepsy, post-ictal EEG will be slow, while in case of non-epileptic attack disorder, post-ictal EEG will be normal. The causes of non-epileptic attack disorder is mainly psychogenic.